Hello guys, welcome back to Clinically Clear. Today we'll be covering a few short important topics for the exams. Fungal sinusitis, 5 marks. Just write what I have written here. Easy 4 out of 5. Okay, I've tried to keep it as concise as possible. So first, fungal sinusitis. Which are the most common causative organisms? You have Rhizopus, you have Mucor, Aspergillus, Alternaria, etc. Just remember three also enough: Rhizopus, Mucor, Aspergillus. First lesion is something known as fungal ball. Now, fungal ball is non-invasive. Remember that. It is non-invasive. It is just fungus that has been implanted onto the wall of a healthy sinus. When we take a CT scan, the sinus appears completely healthy. You just have a mass of fungus implanted onto the wall, either on the sinus or it can even be on the nasal wall. Most commonly involves the maxillary sinus. What is the treatment? Surgically remove the fungal ball. You don't need any antifungal therapy, nothing. Just remove the fungal ball, done. Fungal ball is basically a ball of fungus on the sinus. That's all. Then coming to allergic fungal sinusitis. This is also non-invasive. Here what happens? Because of some fungal infection in the mucosa, in the sinus mucosa, there is an allergic reaction to that fungus. So because of that, what happens on CT, you can see that there's a lot of thick mucus production. This thick mucus production, it appears as an opacity in the sinus on CT, and it takes up metal. Very, very important. This is a very commonly asked MCQ where allergic fungal sinusitis, it starts taking up metal. Because it takes up metal, there is a railroad appearance or a double density sign on X-ray. Just Google up the double density sign or railroad sign, you'll get a nice picture where within the sinuses you'll have two different dense opacities. Why the densities are different? Because of metal uptake. Treatment here is functional endoscopic sinus surgery, where you'll improve the drainage and you'll improve the ventilation of the sinuses. You can give, see, more than antifungal therapy here, it is not the fungal infection that's causing the problem, it is the allergic reaction to the fungus. So FES, to improve the drainage and ventilation of the sinuses, to get rid of all that thick mucus secretion, FES is the most important thing. Next, coming to chronic invasive sinusitis. As you can see, this is invasive. So everything to do with invasion. There is intracranial invasion, intraorbital invasion. How is there invasion? Because on CT you can see that it is eroding the surrounding bony walls of the sinuses. And even when I do the pathological assessment of the sinus mucosa, when you do the pathology, I can see that there is submucosal invasion in the sinus wall. So everything to do with invasion. Chronic invasive fungal sinusitis. Here you have to give antifungal therapy. Then last, coming to fulminant fungal sinusitis. This is a very fatal infection. It is a rapidly spreading fatal fungal infection. It is seen in diabetics and immunocompromised individuals. Diabetics are also immunocompromised only, but diabetics and immunocompromised individuals. Now there are two species that can cause fulminant fungal sinusitis. You have Mucor and you have Aspergillus. The only difference between the two of them is Mucor, there is formation of black eschar. There is deposition of the fungal necrotic, because of the fungal infection, the necrotic material is in the form of a black eschar. Why is that so? Because Mucor has a very high affinity to the endothelium of the arteries. So that is the reason why it is rapidly spreading by vasculature. Aspergillus also very, very similar symptoms. Both are highly invasive, spreads to the surrounding structures like sinuses, nose, orbit, brain, palate, etc. It spreads everywhere through the vessels. Just that Aspergillus, unlike Mucor, there is no black eschar formation. Then treatment here is you have to give IV antifungal, IV liposomal amphotericin B, surgical debridement of the necrotic tissue. Very, very similar to the treatment of mucormycosis. That is also caused by Mucor. Here we are talking only about the sinus part, fulminant fungal sinusitis. Fulminant fungal sinusitis can be a part of mucormycosis. Then coming to complications of sinusitis. I've combined two chapters into one, complications of sinusitis. 3-marker, only single topics. I'm doing only the single topics. 3-marker intracranial complication. Just remember abscess, 3 abscesses. Brain abscess, see, deepest brain abscess, then subdural abscess, then extradural abscess. So 3 abscesses. then meningitis and cavernous sinus thrombosis. So from the dangerous area of the face, cavernous sinus thrombosis and meningitis. So that is intracranial complication. Then there is something known as mucocele. What is a mucocele? Mucocele is basically the cystic dilatation of the mucous glands. Now, in Singi, there is the 3-mark question only for mucocele of frontal sinus. But just by looking at frontal sinus mucocele, you can also write answer for other sinuses because of the orientation. So, mucocele is a cystic dilation or cystic swelling of the mucous glands of the sinus mucosa, right? In the frontal sinus, 90% of the time it is in the superomedial quadrant. So because it is in the superomedial quadrant of the orbit, it will push the eyeball laterally downwards and forwards. What will that lead to? Proptosis. And because of pushing of the eyeball, there will be restricted extraocular movement. That will lead to diplopia. And you have a mass pushing structures around. So you'll have headache. 10% of the time. Most of the time, this is where the frontal sinus mucocele is. Superomedial quadrant. See, here you can see you have a huge mucocele. This is the normal frontal sinus, which is patent. Here you have a huge mucocele that is pushing the eyeball downwards, forwards, and laterally. It is located, it starts superomedially and then grows. Treatment is frontoethmoidectomy. We completely remove this ethmoid sinus air cell caps. We improve the drainage of the frontal sinus. Basically, the whole frontal sinus will just straight away drain into the nose. There's not much obstruction to it, and we remove the mucocele. Of course, it is just dilatation of the mucous gland, right? So we remove the whole frontal sinus. Basically, it becomes a common passage. So frontoethmoidectomy is the treatment. Then coming to a 5-mark question, orbital complications. Basically, which all sinuses are closely related to the orbit? You have the frontal sinus, you have the maxillary sinus, and the ethmoid sinus. Ethmoid sinus is the one that has the highest risk of orbital complications because ethmoid sinus is separated from the orbit by a very, very thin papery bone known as lamina papyracea. So straight away from the ethmoid sinus, it can enter the orbit. Lamina papyracea is very, very thin. So via the ethmoidal veins, it can spread to the orbit. So let's look at some of the complications. See, eyelid edema is actually seen in almost every case of sinusitis. There is no redness, there is no pain, just inflammatory edema of the eyelids. Okay. Frontal sinusitis meaning inflammatory edema of upper eyelid. Ethmoidal meaning both the eyelids. Maxillary meaning lower eyelid. That's it. Simple. Eyelid edema. Subperiosteal abscess. See, now here you have the bone, and here you have the ethmoidal sinus, and here you have the orbit. So because of the infection entering the going through the bone through the ethmoid veins, underneath the periosteum of the bony walls of the orbit, you can have abscess, pus collection, subperiosteal abscess. Again, this will also push the eyeball. So maxillary sinusitis, the subperiosteal abscess will be in the floor of the orbit. So it will push the eyeball upwards. Frontal sinusitis, the subperiosteal abscess will be in the roof of the orbit. So it will push the eyeball downwards. Ethmoidal, it will push the eyeball laterally. So just basic anatomy, if you know, you can get to know where the abscess and what kind of symptoms, how it will cause proptosis. So that is subperiosteal abscess. Then let's say the infection breaks out from the subperiosteal abscess. It goes and infects the orbit now. Then what will happen? It will affect the orbital fat, the nerves, the vessels, the muscles. So all general symptoms. You have an infection within your orbit, orbital cellulitis. The complication is orbital cellulitis. Here you'll have high grade fever. You can have vision loss, which can even be permanent because of the infection of the muscles. You'll have restricted extraocular movements. You'll have headache, and you'll have various other symptoms. Orbital cellulitis. Now, because of orbital cellulitis, there will be pus collection within the orbit as well. So that is intraorbital abscess. Now, this intraorbital abscess also can apply pressure on the eyeball. And how will you get to know there is an abscess? Through a CT scan. Treatment for intraorbital abscess is IV antibiotics and incision and drain. You can just only incise and drain the abscess, and you can give antibiotics, hoping that the infection subsides. Then there are two syndromes known as superior orbital fissure syndrome and orbital apex syndrome. Now, what is superior orbital fissure syndrome? Superior orbital fissure syndrome is where you have deep orbital pain, not deep orbital fissure. You have deep orbital pain along with the palsy of third, fourth, and sixth cranial nerve. along with the palsy of third, fourth. See, these are the ones that supply the extraocular muscles: oculomotor, trochlear, and abducens. So these three undergo cranial nerve palsy. Along with that, you have deep orbital pain. Then you have orbital apex syndrome also, where if you add optic nerve palsy as well as trigeminal maxillary division palsy to the superior orbital fissure syndrome, then it will become orbital apex syndrome. So instead of being just 3, 4, 6 cranial nerve, if it becomes 2, 3, 4, 5, 6 cranial nerve, then it becomes orbital apex syndrome. So what are the orbital complications? Eyelid edema, subperiosteal abscess, orbital cellulitis, intraorbital abscess, and the two syndromes: superior orbital fissure syndrome and orbital apex syndrome. That is it for that is it for complications of sinusitis. I've done only the Singi topics. They can just ask complications of sinusitis, which I didn't really bother to study. If you want, you can study it. That's it. Thank you for watching.